Hello and welcome to our introduction to mechanical ventilation. I'm Katie Scully. I'm the clinical educator here at Inova Fairfax Hospital for the peri-anesthesia care units. And it's my pleasure to introduce to all of you Dr. Bobby Mahajan, who is our medical director
of interventional pulmonology.
And in addition, we have wonderful Frozan Roshan, who is our resident outstanding respiratory therapist. So we're going to go forward today and we're going to talk about how we're going to care for the respiratory compromised patient. And these are our objectives that we are going to hope to achieve here at the end of our program. What does impending respiratory failure look like? Well, what is key is an increased respiratory rate. And a rate of more than 30 is the patient telling you that something is really wrong. Even though you might have adequate oxygen O2 saturations, 95, 96, 97%, if your respiratory rate is climbing and above 30, your patient is telling you something. Know that also you would see an increased work of breathing, use of accessory muscles. The respirations could be shallow, and you could have noisy breath sounds as well. And of course, decreasing O2 sat.
And remember, when we talk about shortness of breath and respiratory failure, again, like Katie said, it's not always just a question that our oxygen levels are low. Really what it comes down to is work of breathing. So our body is meant to only use a few muscles when it comes to breathing. And one is the diaphragm, which moves up and down to breathe. The next one are some of our chest muscles, okay? When we can no longer use our diaphragm effectively, other muscles come into use, like our neck muscles, our chest muscles, and it's really just work. People are trying hard to breathe. One of the ways you can really see that someone is having impending respiratory failure is not only that they're breathing faster, but they're taking harder work, they're doing harder work to breathe, and you actually see them using those muscles. Your diaphragm is what we call an involuntary muscle, so you don't think about it when you're breathing, okay? When your diaphragm is supposed to contract, it moves down, okay? So when we think about breathing, we take a breath in because our diaphragm is moving down. And what ends up happening is when your diaphragm moves down, all of our stomach contents move out. So when you breathe in, your stomach moves out, and when you breathe out, your stomach moves in. When you're really running into respiratory failure and impending failure, what we end up seeing is the diaphragm is one of the first muscles to fail. So instead of taking your belly going out when you take a breath in, their belly moves in. Because essentially, their diaphragm isn't working and it gets sucked in because a patient is trying to breathe hard. So if you end up seeing this, what we call paradoxical diaphragmatic motion, that means that the patient is failing and they need to be intubated, okay? So one thing we can do if we're not sure, because some patients are young and healthy and they can keep working hard, you can put your hand on their stomach and see what happens when they take a breath in. Does their belly come out or does their belly go in? If it's going in, it means they're failing.
So meanwhile, we can try and some different O2 delivery methods to help get our patient over the hump. We know of our typical nasal cannula that we can go from 1 to 6 liters. Then we also have our medium flow cannula that can be humidified. We could have that from 1 to 15 liters. We have also the high flow nasal cannula, which Frozan can show us here. Goes to a machine that is humidified and
So basically, high flow nasal cannula is a high concentration oxygen. All oxygen supplies, we have low concentration and high concentration. Nasal cannula, face mask, non-rebreather, they're low concentration, but the one that we give precise oxygenation, like you're dialing the oxygen, that's called high concentration oxygen, which could be high flow, could be Venturi mask, that we have different numbers for each one, like 24, how much flow, 28, how much flow. So you are giving to the patient precise oxygenation. With the high flow, we have the high flow system and then the different size of nasal cannula. Well, very important to the patient that how precise oxygen we are delivering. And our high flow system will show how much oxygen is delivering to the patient. We have 2 knobs. One is for concentration of, so one is for oxygen and one is for flow, which I can see sometime on the floors that mistakes patient is desaling and everybody go increase the flow and not the oxygen. And still patient is desetting. So, and then the NOPAs is kind of work backward. Like when you decrease the oxygen, that means you're increasing the oxygen. And when increasing the oxygen, it does mean you're decreasing the oxygen. Another important thing on the corrugated tube, when there is moisture, there is water occlusion, that's also causing low oxygenation on the patient. Sometimes it's around the patient's neck, sometimes it's laying on the bed. So all the moisture is occluding in the tubing, and that's caused also low oxygenation and low saturation. These points are very important with the high flow system for the patient.
And fortunately, we have wonderful respiratory therapy to assist us when we have a patient on a high flow nasal cannula such as that. There's also the oxidizer, which is a O2 device in which we have the nasal prong, and it also has like a pillow. So it has an O2 reservoir, so we can have higher concentrations of oxygen in a nasal cannula format. And I think then further, we had talked about our 100% non-rebreather masks that we're pretty familiar with in our vacuum environment, but we do want to make sure that the valve is intact and also that our bag here is filling up with oxygen. So here again, we have a reservoir for the patient.
And our flow meter is all the way up to 12, 15 liters, especially when the patient needs to be intubation. That's very important that we are oxygenating patient 100%. And the flow is really important. It should be all the way up to 12 and 15.
One thing I want to stress is these are methods providing oxygen. Okay, these don't necessarily provide any support for ventilation in terms of how your work of breathing is. So part of understanding oxygenation and breathing and ventilation is that oxygenation is providing oxygen to the airways and the air sacs, whereas ventilation is bringing air in and out. So there are two very distinct different approaches in terms of what's required for us to breathe, but there are two very different ways of treating those different problems. So, oh, do you want?
No.
Okay, so I'm going to talk a little bit about different ways of mechanical ventilation, both invasive and non-invasive. Now, I'll tell you this, that everyone looks at any kind of apparatus past any nasal cannula, high flow, as being really confusing. Okay, so my job is to try and break it down as simply as I can. So I try and talk to it as if what I remember, and frankly, really we want to know the basics. Okay, I want you guys to understand why what a mechanical ventilator does, what a BiPAP, what a CPAP does, and frankly to know the alarms of what they mean. Okay, but understanding the physiology of what they're doing makes it all much clearer. Okay, so if we look at non-invasive positive pressure ventilation, this means we're not putting anything directly into the airway. We're not putting an ET tube, we're not putting any kind of tracheostomy, anything of that nature. Really what we're doing is we're supplementing work of breathing. Okay, so a BiPAP, by definition, is called bivalve flow, meaning that it's providing us for positive pressure in and pressure out. So essentially, when we're working on breathing, this is the ventilation part, where we're saying that the work of breathing is inadequate for a patient. They're unable to keep up with breathing. And what we see that is most commonly where this is effective is emphysema patients and for heart failure patients. And the reason for that is because they're not very strong. They can't keep up with the load that's been put on them. So BiPAP essentially is delivering positive pressure at alternating levels. So if you guys have seen people who have a CPAP for sleep, okay, all a CPAP is doing and a BiPAP are doing are essentially keeping the airway open and either giving pressure to allow air to get into their chest and changing the pressure to allow air to get out of their chest. So I'll start with CPAP first. This is the exact same kind of thing we see on people who sleep at home with a CPAP machine. Typically, when we take obstructive sleep apnea, when they take a breath in, their airway closes, okay? And as a result of that, they're working hard to breathe when they're sleeping. Now, they don't get to the point where they're really hypoxic or having shortness of breath because they don't recognize it. When we have a patient on CPAP inside the hospital, the reason we use this, it provides us positive end expiratory pressure, or PEEP. Okay, and that's the amount of pressure to keep the airway open continuously. So what CPAP does, it just sends the airway open with a column of air. And as a result, you can exchange air very easily, right? So if you take a breath, you'll be able to move air in, move air out without any kind of obstruction. Okay. Really what we see more on the floor in patients who are short of breath or having trouble breathing is a BiPAP. And what a BiPAP does is very similar to a CPAP in the function that it's a large mask. You guys have seen how annoying some of those masks are, and patients hate them, but it creates a seal around their airway, their nose and their mouth. And by doing so, it allows the patient to be able to get a breath in, but allows there to be support when they take a breath. So the actual BiPAP machine senses when a patient triggers to take a breath in, it senses the drop in pressure, and essentially it pushes air in for them, okay? And then once they finish their breath, it allows the pressure to drop down and the air comes out. So essentially you're supporting ventilation. They're not doing the work of breathing they were before, because instead of their muscles having to breathe, the machine is pushing air in and allowing air to come out. So where do we typically see this? In patients who are fatigued or weak or have emphysema, it's a way of saying, well, their oxygenation isn't that bad, but they're just tired from breathing. So can we temporize them by putting a BiPAP machine on them? What we end up seeing is that these emphysema patients, these heart failure patients, you put a BiPAP machine on them and they fall asleep and they're comfortable and relaxing. And the main thing is because they've been at the gym for 24, 48 hours working hard to breathe. Okay, you can put oxygen into that BiPAP machine, so you pump up the oxygen as well. But really, it is the difference in pressure between the inspiratory flow and the expiratory pressure that allows air to move in and move out without difficulty. And really, it's just giving them support. It's not doing anything else except improving the way that air goes in and comes out. Okay, typically, what we see in these patients, you'll keep them on a BiPAP machine for 24 hours. You rest them, let that energy come back, and then you're able to wean them slowly off the BiPAP. Okay, so that's really when we look at supporting ventilation is by BiPAP and CPAP. Okay, some of the contraindications we look at for BiPAP, if someone is not alert enough to be able to kind of keep a BiPAP on their face or trigger the machine, that's not appropriate for BiPAP. We try and avoid it in people who have a big or a full stomach, or someone who has poor gastric motility, because you're also putting air not only into the lungs but also into the stomach when you're doing this, so you can get someone can vomit and aspirate. And then with the pneumothorax, that's something we try and avoid, along with facial trauma, because honestly, you're not going to get a good seal on the mask. Okay, but otherwise, in patients who are cooperative, who are able to tolerate this ventilation, it's it's really changed what we do with mechanical ventilation, because we can temporize them on a BiPAP as opposed to having to intubate them. Okay? So the next thing we kind of look at is indications for intubation. Okay, now this is always it's easy to say these, right? But a lot of it is just looking at the patient, because if I can look at some of these numbers and in out of context of how the patient looks, you can end up seeing them and say, oh, this person needs to be intubated. And you walk into the room and they look great, right? You say, they might look great. They might not stay looking great. But when do we start intubating someone? But what we worry about are a few things in terms of the oxygenation, again, the ventilation, and then the respiratory rate. The respiratory rate being one of the most important things, because again, when someone's breathing greater than 30 a minute, they're really using a lot of energy. They're not going to be able to maintain that. Even a 20-year-old breathing 30 breaths a minute for 4 or 5 hours is going to eventually fail, because they're going to use up all their ATP to do so. So when we worry about SaO2s, when we see anything, an FiO2, we worry about less than 88%. I mean, for oxygenation of anything less than 88% saturation, we worry about that. It means we're not oxygenating enough. There's a mismatch between the blood flow and the actual oxygenation. So when we see a PaO2 of less than 50, in an FiO2 greater than 60, we worry, okay, in the sense that we're not oxygenated. When we think about the idea of someone having oxygenation, we look at a curve in terms of what their blood level of oxygen is, which we call the PaO2, and how that correlates to a saturation, okay? The reason we look at that is because below a blood oxygen level of about 55, we start seeing less than 88% saturation. That means there's not enough blood, there's not enough oxygen in the blood to actually saturate all the hemoglobin that's delivering oxygen to the body. Okay, so when we see that and we start supplementing their oxygen and they're still not coming up, we know that they're not going to maintain their oxygenation. In those situations, we have to intubate them, because that way we can get as much high volume of oxygen into them as possible to recruit their oxygen stacks. PCO2. So this is important, and we talked about this a little bit in terms of ventilation. Part of the biggest driver for actually breathing has nothing to do with our oxygenation. Okay, the biggest thing it has to do with is our CO2s. When our CO2 goes up, meaning the levels of CO2 in our blood start going up, our body senses that and it says, okay, well, in our brain, we have to breathe faster to maintain a certain pH of about 7.4. Okay, it's an incredibly sensitive way of changing your breathing rate. Okay, so when we are not breathing well, meaning that we're not keeping up with our ventilation, our CO2 starts to rise. Okay, and when it starts to rise, what does it make us do? It makes us breathe even faster. Okay, the problem is when you're breathing faster in a patient who doesn't have the energy or is too weak to do that, they start failing even faster and their CO2 goes up and up. The problem is your CO2 is an acid. Okay, and as a result, your CO2 in your blood, as it goes up, your pH comes down. So normally you want it to about 7.4. With hypercapnia, meaning your CO2 is going up, your pH drops. And again, it's this terrible cycle. It drops, it's more acidic, you try and breathe faster to get it out, and you start failing. Okay, so this is, again, if you're checking ABG, looking at an elevated CO2 and a low pH is an indicator of failure. And then the last thing we talked about also in terms of respiratory rate, again, people cannot maintain at 35 breaths a minute for very long, especially in our population, especially if they're older, emphysema, heart failure. So in those situations, you need to be able to intubate them. One thing that we talk about, which we don't deal with as much, but we see in the recovery area especially, is that people who can't protect their airway. Okay, number 1, 2, and 3, if someone doesn't have a gag, they need to be intubated. Okay, in the setting of all of these, meaning that they're failing, their mental status is poor, and their gag, which is one of the few things that maintains the airway and protects the airway, if it's not present, their risk of aspiration is incredibly high, so we intubate them. And then along these same issues, GCS of less than 8, seizures, neuromuscular problems, anesthesia, angioedema, those are all situations where we say, look, this is mechanically there's something wrong. But everything, including these 3, is really what we worry about. Okay, we say we need to intubate them. I will say one other thing about intubation. Intubation is not a failure. If someone is so sick and so short of breath or hypoxic that you have to intubate them, don't say, oh, well, it's terrible, we had to intubate them. You have to intubate them to maintain them. Okay, it's better to intubate in a controlled setting than an emergent setting. So I've seen a ton of people who say, oh, well, I can keep trying for 4 or 5 hours to keep them from being intubated. In those situations, it becomes an emergent intubation, and then it becomes really a much more complicated than it can if we do an organized intubation. So don't feel as though you failed if someone needs to be intubated. Okay? So the intubation procedure itself, we've seen this before. I don't know, Katie, if you want to go into some of the pieces first.
Right, and I know our PACU people here are really pretty adept at all of this, but you want to just tell me, where do you find your airway box? On the MSEC card, that's right, it's on the top of it, or if we've used them all up, then we're going to find it in the MSEC card itself on the bottom drawer. And essentially what we're going to do is we're going to organize ourselves into roles, and we're going to, of course, call for help. And when you bring over the AMBU or the airway box, we're going to have our patient that at this point in time, we would have a friend bagging them for us. And what we would be doing is anticipating what anesthesia needs. And by getting them the airway box, we would also maybe help facilitate the type of blade they would want. The curved blade is called the Mac. The straight blade is called the Miller. We have various sizes in our airway box. We're going to want to get suction ready to go at the bedside and put that right on the chest for them. And a number 8.0 ET tube is the most commonly used, or it's a common size ET tube for our adult population. And when you pull it up out of your airway box, it's all good to go with your stylet in place and your syringe. Yep. And so with that, you want to make sure that you're bagging your patient before they intubate, and then afterwards, we're going to be checking placement with breath sounds. Okay, and then we'll follow up with the chest X-ray. And we can also check with our CO2. Exactly. Thank you so much. So we have a color metric in here as well. Okay, so we will do that, and then we will have a temporary tape. And then once we know that our ET tube is in the right position, and how would we know that on X-ray? What would we see? Where would that ET tube lie? 2 to 3 centimeters above the
Centimeters
carina, where the bifurcation is in the lungs. Perfect, that's right. And then our wonderful respiratory therapist will come to the bedside for us and secure our ET tube with this device, which is called an anchor fast.
It's coming in this box, and this is RT's job to secure the ET tube after getting taped with the anesthesiologist or with the pulmonologist. So we put that around the patient neck. So it's coming basically like this, and it has a sticky part. We remove this, we clean patient's face, and then we try to form it on the cheek, and we put pressures, stay there, and then we secure the ET tube. With this, goes through the slide, and we press that. So that way your ET tube is secure, and then this goes under the patient head. So this is the way our ET tube is secure.
Thank you. And when we assess our patient, we're going to note the size ET tube that is placed and where it is at the level of the teeth, what millimeter it's at. So it could be like a number 8 ET tube at maybe 23, cms at the teeth. And then every 4 hours, RT will manipulate and move the tube side to side. Okay, and then this is typically changed every 48 hours.
And then we have the inline suctioning. So that's gonna come with the circuit, and this is gonna be hooked to the suction, and it's gonna close system suction. So the way you suction, we go gently, watching the vital sign, and you gently suction. And sometimes if we see something on the suction tube, we flush this and it clean that. That's basically closed suction system.
You flush the tubing, not in the patient, right?
Of course not. But when you're coming out,
Just flushing the tubing.
yes.
But you're not putting in saline inside the.
Sometimes if patient has a thick secretion, per doctor order, we can put fluid and we could suction also.
But that's not routinely done.
Not routinely
Right.
done.
Okay, very good.
So mechanical ventilators, all right? So I'll tell you, again, I've said this before, is that this is really just a dumb machine that blows air and then blows it out, okay? So the complicated nature of it is only because patients are sick, but more importantly, just understanding the basic physiology behind it and the modes behind it make things seem very simple, okay? So when we think about, when we take a breath, we take in a certain volume of air with every breath, okay? And essentially the way we look at this, in normal breathing, we breathe a certain volume and a certain number of breaths for every minute, okay? That's exactly what we're trying to emulate in a ventilator. The only difference when we look at a ventilator versus normal breathing is that when we do normal breathing, it's negative pressure, meaning we're sucking air in because we make our chest have negative pressure by our diaphragm dropping. The pressure within our chest is lower than atmospheric pressure and air moves in. That's it, okay? So it's very low kind of wear and tear on our lungs when we're taking a regular breath. The difference with a ventilator is that, again, we can set how much volume we put in. We can set the rate at which we give every minute. And the only difference in terms of how the air goes in, that is being positively pushed in versus being brought in gently from negative pressure on normal breathing. That's where we run into issues with the ventilator, is that it's positive pressure. So there's more risk of causing injury to the lungs with positive pressure, okay? And what do those things mean? The rate at which we breathe and the volume we take in, that really is called what we say minute ventilation, okay? Minute ventilation is how much we bring in and how much we move out over a minute, okay? And we need to be able to sustain that to sustain our functionality of the rest of the cells in our body. Okay, so in general, we try and keep our minute ventilation, meaning the rate times the milliliters we take with each breath, about 6 to 8 liters per minute. So essentially, if we say we breathe in 500 milliliters per breath, okay, times 10 breaths, okay, equals about 5 liters per minute. Okay, so if we say that we're taking 500 mLs per breath, to get to 6 to 8, we probably want to be doing 12 breaths per minute. Okay, so the goal is with everything we do with a ventilator is to maintain appropriate minute ventilation. Okay, so there's two, and I'll come back to this in a second, but if you look at the two main basic modes of ventilation and then the hybrid kind of mode of this, which I'll talk about at the end, we have two ways of ventilating people. We do what we call volume-based ventilation or pressure-based ventilation. And essentially it's a control mechanism, meaning that this is controlled by the amount of volume you put in. So you can set the volume you want to put in, versus pressure ventilation is you can set the amount of pressure you want to be created in the chest independent of the volume. So we look at this, volume, we control the volume, we cannot control the pressure, okay? In pressure ventilation, we control the amount of pressure we want, but it means a variable volume. So I'll come back to this. When we talk about volume ventilation, it delivers a gas at a preset tidal volume. So we can dial in how much volume we want. We say for every breath, we want to be able to, every time the ventilator gives a breath, it gives 400 milliliters of air, okay? So every time, the ventilator, again, is a dumb machine. It just says, okay, well, the patient is triggering, okay? So meaning that the patient takes some kind of breath. It initiates a breath. The ventilator senses that, and it pushes in 400 mLs of air, okay? Now, when we push air into the chest is a closed space. So with any movement of air, the more air you have in a closed space, you develop pressure. Okay, and that pressure is what we look at in terms of the inspiratory pressure. How much pressure is in the chest? And the way we represent that is called a plateau pressure. So a plateau pressure is the amount of pressure that's in the chest as a result of putting one breath in. Okay, now pressures are different. Pressure depends on the stiffness of those lungs, right? So if we put in a lot of 500 mLs of air into a very stiff lung, the pressure is higher. If we put in 500 mLs to a very kind of elastic lung, the pressure is lower, okay? And that's what's known as compliance of the lung, the ability of the lung to stretch, okay? Now, patients who have really sick lungs, like ARDS or scarred up lungs, they have a very poor compliance. When you put air in there, they don't stretch very much, so the pressure is really high. Whereas in someone who has emphysematous lungs, they're very floppy and stretchy. You put in the same amount of pressure, the pressure isn't very high, okay? So essentially, every time we put in a amount of volume into this ventilator, we say we're gonna do 500 mLs for every breath, and we're gonna say we're gonna do 12 breaths per minute, okay? So if we completely paralyze the patient and we didn't let them breathe at all, okay, they wouldn't take a breath. As a result, every 5 seconds, it would push in 500 mLs of air, okay? They didn't do any kind of triggering at all, okay? But what the ventilator does, it senses the patient trying to breathe. So every time the patient takes a breath, it'll sense that and it pushes the air in. Because they're trying to be synchronous with the patient. They're trying to give a breath to the patient when they want it. The problem is that if the patient is breathing above that 12 breaths per minute, it gives them that volume every single time, okay? So part of it is, this can be challenging to keep someone synchronous to the vent, because if they want to breathe, it's going to give them 500. It's a dumb machine. It just says every time it wants to breathe, we give it 500, we give it 500. So if they're breathing at 30 breaths a minute, even though we want it at 12 breaths a minute, it'll give it that 500 over and over again, every time the patient tries to breathe. So that's why it's important to try and get the patient sedated, calm, so they're not over breathing the vent, okay? So the problem we run into also is when we talk about the plateau pressure, if you keep taking those breaths over and over again, that pressure builds up, and you can have what we call a high plateau pressure. A plateau pressure is really representative, again, of trauma to the lungs. The higher the plateau pressure, you're just stretching and injuring the lungs more than you want. So that's one thing we look at, and one of the alarms we worry about. If a plateau pressure is too high, okay, usually we worry about anything over 30 is what we're looking at. Is that means you're putting so much pressure into the lungs that it's kind of causing inflammation and injury to the lungs. So that's one of the alarms we see all the time, elevated plateau pressure. That means that based on that, there's too much pressure in the lung. We have to adjust, okay, our ventilator. The other issue we run into, which we can see with a volume control pressure, meaning we only focus the volume, we control that volume, is that sometimes the peak pressure is elevated. And the peak pressure essentially is the amount of resistance within these airways that we're looking at, meaning that the trachea down to these main stem airways have a resistance, right? Our normal airways are about anywhere between 16 to 20 millimeters in terms of your trachea, and then 10 to 12 millimeters in terms of your main airways. Okay, so if those get narrowed by mucus, some blood, a small tube, your resistance goes up, and as a result, your peak pressure goes up. So if we set our peak pressure what we want it to be, we want our peak pressure to be 15, right? And we see here an alarm that's going off that it's higher than that, it means there's some source of resistance there. Probably 8 times out of 10 is because there's a bunch of mucus in there. So that might say, okay, well, maybe we should suction the airway. Maybe we should put the inline catheter in suction and see if the peak pressure comes down. The reason we worry about those things, the plateau and the peak pressure with volume ventilation, is because you always have a risk of having a pneumothorax or something of that nature, or getting barotrauma because the pressure is too high in the lung. Okay. Again, remember, volume control ventilation, you control the volume. Okay, so we can determine how much air goes in with each breath. Okay. When we talk about pressure control ventilation, this means we can control the amount of pressure that is going into the patient, meaning that we set the pressure, but we don't set the flow or the amount of volume that goes in. So as a result, we say, oh, well, we don't want to injure this person's lung. So let's make sure the plateau doesn't go above 30. Okay. Again, depending on how stiff their lungs are or how compliant their lungs are, you might put 20 cc's of air into someone's lung, but if they're really stiff, their plateau or their pressure already hits the goal we're trying to get to. And that way we're not ventilating them. We're not giving them enough volume. Okay. But we also might say, well, this prevents the volume going too high. So in an ideal world, we end up setting a pressure in terms of what we want, and we're able to give them enough tidal volume so that they can actually achieve that pressure but still get enough oxygen to the patient. So the problem here is that, again, you might be able to prevent them from getting injured, their lungs, but you're not getting enough air and oxygen to them. So this one doesn't work either perfectly. The issue you run into is that you can't determine or predict the amount of tidal volume with each breath. Okay, so when I was training, this is what we had. So all day you're sitting there making little tiny adjustments to the ventilator, checking the ABG, looking at their peak pressures. A lot of it came to us just standing at the ventilator making adjustments all day. So again, they realized that we can be smarter than this. So essentially they put in what we call hybrid modes, okay, or dual modes, in the sense that you can say, well, instead of just having one or the other, you can have the best of both worlds. Okay, so instead they look at what we call pressure regulated volume control, meaning that the ventilator is way smarter than us, even though it's a dumb pump that pushes air in. It senses with every breath the amount of pressure that is needed and adjusts the volume to make sure that you get enough volume, but you don't do too much pressure to injure the lungs. Okay, so the reason I give you all that background was what things we had before in terms of the volume and the pressure. Now we're in a much better place that you can set that to what you want and usually just be okay with it. Okay, but really what we look for are changes in the peak pressure, meaning there's an alarm that goes off, there's too much resistance in the airway. So you think about, do I have to suction this patient? Is the tube not working correctly? Is the balloon not working? Something of that nature in the ET tube. Or you see an elevated plateau pressure. Do you worry that there might be too much volume going in? Could the patient have a pneumothorax? Could there be a lot of fluid around their lungs? So in general, in most situations, we're worrying about the actual, the lungs themselves and the alarms that come up with that. So what I'd say is that a lot of the way, this is what we're using most commonly, because honestly, it's the smartest method of ventilation. We don't have to worry about it being just one or the other. We have a combination of the two in kind of a hybrid model. And also what we end up seeing is the bivent itself this is a pressure release ventilation. So it's kind of more rescue when we talk about ARDS. And the inspiratory flow is shorter than the expiratory phase. The reason for this is a lot of times when we take a breath in for a patient, if they don't exhale all the way before the next breath is coming, you're putting air on top of air that was already in there. Okay? And as a result, you start building up the pressure within the chest. And that's what we call auto-peak. Okay, but really what we end up seeing is that by doing this, you allow the patient to get air in all the way out and then appropriately put in the next breath. But it really minimizes the amount of injury that you see to the lungs, especially with ARDS, acute respiratory distress syndrome. Okay, so we talked about this a little bit in terms of the tidal volume, so the number of air delivered with each breath. And really what we end up seeing is that this is the normal amount of air we're supposed to see. We try and emulate as much as we can to normal ventilation so that we're not doing something abnormal and it's injurious to the lungs. What we look for is usually 6 to 8 cc's per kg of ideal body weight. So for example, we know all those patients that they might be 6 foot tall, but they only weigh, 100 pounds. We're not looking at just their weight. We're looking at their ideal body weight for a 6 foot person. Okay. So, and there are charts we can look up. So it's not the height, it's the weight. Okay. And the reason we do 6 to 8 cc's is that that's what we call lung protective for ARDS. We're not putting too much air in. In these ways, we'd rather err on the side of less air than more air. Okay. So that's how we determine what the tidal volume will be. So tidal volume in terms of how we breathe in, this is normal breathing. So what we call the actual tidal volume is when we're effortlessly breathing, okay? So it usually stays within this kind of framework. There's volume left over in the lungs, even every time we breathe. And when we take a full breath, we breathe all the way to our inspiratory reserve, meaning we can take everything in and then blow it all out. Okay, so really what I want you to focus on that we're trying to emulate whatever we can for normal breathing on the ventilator. Okay, so there's a couple of ventilator settings we deal with, okay? And really I want to give you the basics of this, okay, in terms of what we would expect and what you can have changes in this, and I'll talk to you about what things change when we do this. But really what we look at is the mode, meaning volume control, pressure control, or PRVC. The rate, meaning what rate of breaths we want to do per minute. So for example, if you want 10 breaths per minute, the ventilator is going to deliver every 6 seconds. Okay, and it ensures it gets those 6 breaths in. The FiO2 is the percentage of oxygen. So normal air, when we're breathing now, is 21% oxygen. The rest is all nitrogen and carbon dioxide. So what we end up seeing is that every time you go up by 1 liter of oxygen in terms of supplements, it's about 3% increase in the FiO2. Okay, so if I say, I put Frozan on 1 liter of oxygen, instead of getting 21%, that means she would be getting 24%. If I put her on 2, she'd be getting 27% because every 1 liter equals 3% of oxygen. Okay, so that is dependent on some patients need a higher level of oxygen in their blood to actually maintain an 88% saturation. So that means that if they don't have that, we can turn up the FiO2 so the concentration they're getting is higher and higher to get more into their blood. The issue we run into when we get too high of an oxygen concentration for approximately 48 to 72 hours, there could be some toxicity. So that's why we try and keep on the minimum amount of FiO2 possible to stay above 88 to 90%. Okay? So when we look at all of this, really what we want to make sure is that we're able to provide enough oxygen and ventilation. Now, when we talk about patients who are healthy, if I put someone on a non-rebreather mask, really what we want to provide as much saturation of their hemoglobin, which carries all the oxygen to all over their body, as possible. So a normal person will have an oxygen content of about 100, okay? And that should make you about 100% saturating oxygen. And the reason for that is above 60 of a concentration of oxygen in the blood means you've saturated pretty much all of your hemoglobin, okay? The problem is in these patients, when they can't get actual blood and oxygen to match together, what ends up happening is they have a lower oxygen concentration in their blood, and therefore the amount of hemoglobin that has oxygen on it, meaning the oxygen saturation, is low. So essentially, if I put someone on 100% oxygen who is healthy, if I put Frozan on 100% oxygen, the concentration of oxygen in her blood should be about 500. Okay, it should be really high, right? And the reason for that is because she has normal hemoglobin. She's carrying oxygen appropriately. That's why when we see an anesthesiologist about to intubate someone, they don't care about anything except giving them more oxygen. The reason is that they can bring their oxygen concentration in the blood to 400. As it slowly drops down, they have a bunch of time before it gets down to 60. So they have about a minute, 2 minutes to actually do nothing while the patient is still 100%, okay? In this situation, if we end up putting someone on 100% oxygen and they're saturating only at 80%, that means there's really damage to the lungs. They're not able to get any of that oxygen into their bloodstream and increase their concentration. So that means they're sick, okay? And essentially, when we talk about the oxygen toxicity, This is not uncommon in the sense that we need really high levels of oxygen to actually support someone. That's when we talk about these different methods like ECMO and things of that nature, because we just can't support them by giving oxygen to their lungs because their lungs are too injured. And as a result, we have to bypass their lungs through that circuit of ECMO. PEEP. So PEEP is interesting in the sense that we look at what does a PEEP do. PEEP is really positive end expiratory pressure. Okay. So if you guys look at the ventilator, it always says, oh, 5 a PEEP, right? Or you turn it up, but traditionally it just says 5 a PEEP. The reason for that, it keeps the airways and the lungs open so they're not opening and closing with every breath. Okay, so for example, when you have a balloon, you're blowing up a balloon for your kid's birthday party, or some of your birthday parties, or just for fun. You blow in on the balloon. At the beginning, it's really hard to blow up the balloon at first, right? Because you have to overcome that initial part of pressure. Okay, that's what we call kind of a hysteresis curve. Once you've gotten past that first pressure, the rest of it's really easy to blow up. Okay, it's the same thing for the lungs. When you have a ventilator and the lungs, the airways, and the actual air sacs are open, and then they breathe out and it closes, when you have to open all the way again, it's inflammation and injury to those air sacs. The PEEP just keeps them a little bit open, so they don't have to keep opening and closing all the way. Instead of going from like this with every breath, it goes like this. So it's easier for those air sacs, just like a balloon, to open up when it gets air. Okay, so when we put that in the ventilator, it really comes down to we want to minimize the amount of injury to the air sacs by doing that. Okay, so that's really what PEEP does. The second part of that is it's at end expiration, it keeps these open, but this adds to your plateau pressure. You're adding more pressure when you add PEEP. So if you dial up on the PEEP and change it to 10, 15, 20, that pressure within the chest is going to go up too. So you have to be careful in terms of how you do this, okay? And as a result, other thing I would say is that as the pressure builds up in your chest, blood return through your venous system is dependent on pressure, meaning that if the pressure is too high in your chest, it impedes blood flow back to your heart, okay? So as a result, patients' blood pressure might get low because they're not getting as much. So what we end up seeing is that we don't want to increase the PEEP too much, because when we increase the PEEP too much, you impede that flow back and they can get hypotensive. Sometimes what we end up doing is, it's funny, you turn down the PEEP when someone's blood pressure is low, the venous return comes back to the heart and their blood pressure comes up. So those are just things to think about as opposed to just turning up the PEEP just to do it. We really want to use it only when we have to. So pressure support, very similar in terms of the BiPAP we talked about. With every breath, it senses that the patient's trying to take a breath and it gives it some support, okay? Really what we end up seeing is it helps regular breathing, but really what we want to be able to look at is assist the patient's breathing. And sometimes when we're trying to extubate someone, we put them on pressure support because the only thing it really does then, it overcomes the resistance of that tube. Because the tube is like breathing through a straw, right? So it's work to breathe through the tube. By giving you some positive pressure or pressure support, it overcomes that work of breathing from the tube and kind of simulates if you're breathing normally. So that if someone can breathe on their own with some pressure support, it shows that they can breathe without a tube. Okay, we want to be able to kind of simulate that as much as possible. So any questions about, I know it's a lot of information, but really what I want you guys to understand, it really is a dumb box. It does whatever you guys want, but it's really just doing what you guys see every single day. It just put numbers to it, okay? And it gives you alarms, which normally, half the time I'm like, oh God, there's an alarm going off. It really means something, okay? Meaning that as long as you know what the cause of that alarm going off is, then you can understand it and you can make an appropriate adjustment. But the benefit of seeing a ventilator on a patient that is in respiratory failure or distress is that the changes you make, you can actually see real-time changes with an ABG. Meaning you get an ABG, you see that something's abnormal, meaning that the CO2 is too high, the pH is too low. You can change that, meaning that you turn up the ventilation, you turn up the minute ventilation, and you check again in 30 minutes and you see a change, you see an improvement. So it's constantly making changes to the ventilator to adjust and come to the right kind of physiologic norm for the patient. So I'll talk about this briefly, but really what we look at with ABGs, okay, and this is a normal ABG. We look at the amount of kind of pH or the acidity of our blood, the O2 content like I talked about, meaning that it should be close to 100% in a normal person, the CO2, meaning a representation of ventilation, of how well they're ventilating, is their CO2 high or low, normal is about 40, and they're bicarb. And this is really dependent, the bicarb is really a representation of kidney function. Your kidneys are way smarter than anything we do. So they are able to adjust to your body pH very easily. What we talked about before is that a pH of less than 7.4 or 7.35 is considered acidic. And usually that's because there's either an acid from, poor circulation, in the sense it's a metabolic cause, or it's because your CO2 is too high, meaning that you're not ventilating enough, your tidal volume is not high enough, and as a result, you build up CO2 and it gets acidic. Versus it being basic or alkalosis, meaning that when the CO2 is low, you're breathing too fast, you blow off some of that carbon dioxide, and your pH is too high, okay? And these are how we look at, is it secondary to a respiratory cause or a metabolic cause? And what I want you guys to focus on is a respiratory cause. Usually that means that their CO2 is too high because they're working hard to breathe and they can't blow off the CO2, or it's too low because they're breathing too fast. The worst thing you can see is that someone is alkalotic, meaning their CO2 is really low because they're working so hard to breathe, and then you check it again and their CO2 is really high because you hit that threshold where they were really tired and now they're failing and they can't breathe fast enough and their CO2 is rising and it becomes acidic, okay? But the most important thing you see is the most telling predictor of how we breathe is our pH and our CO2, which are two linked together, okay? So there's some respiratory imbalances we were talking about. When we talk about respiratory acidosis, the main thing we worry about is your CO2 being too high. And usually that's because they're failing. They're not ventilating enough. They're too short of breath. They're too weak. And their CO2 starts rising because you guys have all seen this. The patient's working hard to breathe and all of a sudden they kind of get loopy and get sleepy. That's because they're worn out and their CO2 is going up, okay? And sometimes we see this with a number of different things. For us, what we're really focusing on is poor ventilation. Okay, they're not breathing enough. Okay, and alkalosis is when they're hyperventilating because they're at 35 breaths a minute. They're trying to compensate for the fact that they're short of breath. They blow all their CO2 off, and then they're alkalotic, right? Which is okay for a little while, but then they fail. Okay, so this is what we talk about respiratory alkalosis and respiratory acidosis. Okay, metabolic changes are involved, but really what we worry about in kind of the patients we're talking about are when we talk about a metabolic acidosis, there's an anion gap, okay? And an anion gap really means that there's some other acidic kind of molecule in their blood that's not supposed to be there. The most common one we see is lactic acid, right? And your body produces lactic acid when it's not getting enough blood, okay? So as a result, when we see a metabolic acidosis, the most common reason for that is they're not getting perfusion, they're not getting enough blood to their body from sepsis, heart failure, and their body says, well, I can't function, I'm not getting enough oxygen, so it functions by making acid. And that's when we see what we call metabolic acidosis. The terrible part about this is what happens to your breathing when your blood is more acidic? You breathe even faster, and as a result, you fail even more, okay? So it's a terrible cycle our bodies are, okay? And a metabolic alkalosis is usually because we're losing some kind of proton or molecule from our body, usually excessive vomiting, diarrhea, diuretics, those kind of things. Okay, so those kind of things you fix the metabolic problem. Okay, so I'll do these.
Just do like one example.
One example
would be great.
Okay, so if we look at this from a case number 1, okay, we say, well, what is the pH? So is the pH high or low? Because we know 7.4 is normal. Okay, so it's low, so it means it's more acidic than it should be. And we see the CO2, we said 40 is normal, so this is high, right? And these, the base is about the same, a normal base is about 24 to 28. But we see that their PaO2 is only 65, so it's not as high as it should be, okay? And we see their saturation is low, it's getting lower. It's still normal, but on the low end of normal. So in this situation, what we'd say is that the CO2 is high, the pH is low, and this bicarb is normal in the setting of someone not oxygenating and ventilating very well. We see they have a respiratory acidosis, okay? And this is very common to see. The reason we worry about this is usually below 7.1, when your body gets that acidic, your heart function starts to get compromised. So we always want to try and catch this as early as possible and intervene on this. What might we do? If this person was on the floor, you would say, well, you increase their minute ventilation. You would say, well, maybe we put them on a BiPAP machine to get more ventilation going. If they're intubated, what do? We can increase the rate or increase the tidal volume. Because again, it comes down to you're improving the minute ventilation. You're improving their ventilation overall, and they get rid of some of that acidity in their blood. Okay.
So here we have an example.
Okay. Oh yeah. So this is a perfect example. Okay. So we ended up seeing that the vent settings, like we talked about it here, the PCO2 and the O2, what we could do in this situation with this patient, again, we see that the pH is low, okay? The PCO2 is high, okay? And we know the PaO2 is low. So how do we adjust this? How would you improve the pH and decrease the CO2? Yeah, so you could say, well, I have to improve the minute ventilation, so I can either turn up the rate or turn up the tidal volume. Now, both of those depend on the situation of the patient, right? Meaning that if the patient's already breathing at 30, right, that's not going to help by turning up the rate. You might say, well, I have to increase the tidal volume there, okay? So those are the kind of things we talk about, but more importantly than anything, it's not necessarily our job on the floor as nurses, as a respiratory therapists to say, well, this is what we have to do. It's more recognizing that something is abnormal. Okay, and then you work as a team to make the best decision. And frankly, it's everyone knowing the patient in terms of making the decision of what to do next. Okay, we talked about this a little bit. What causes a peak inspiratory pressure to be high? The peak, remember, is resistance. Okay, so that ET tube might just be having plugs in it. Okay, there might be mucus in the main airways. Okay, you might have a bronchospasm, meaning the patient's asthmatic or has some bad emphysema, and essentially their smaller airways get narrow, which increases the resistance. A pneumothorax can happen, meaning that there's more pressure on the airways, or the patient just might be biting on the tube because they're unhappy they're intubated, okay? So checking all those basic things first are very important. And then you worry about why is the pressure not high? The most common thing we see is, well, the vent fell off, okay? It came off the ET tube, or the cup isn't working, meaning there's not a good seal of the tube in there. Plateau pressures, again, this is a representation of the stiffness of the lungs, okay? The lungs are too stiff. Now, it could just be that their lungs are very diseased and scarred, and that's why the plateau is high. But the easy things to check are, well, is there anything going on? Is the tidal volume too high? Do they have ARDS, which we know about, we said. Part of it is, do we bring down the tidal volume then? Because if the plateau's too high, we're causing injury to the lung with every breath. And over days, that can cause a lot of damage and inflammation. So we say, how do we change the rate and the volume? So for example, in order to keep the same minute ventilation, what we might do is say, okay, well, I'm going to go up on the rate of breathing, but I might come down on the volume. Okay, so by coming down and up, we still maintain an acceptable minute ventilation, but we're changing the dynamics and the pressure within the chest. So ventilator alarms. All right. Now I tell you something. You guys all know this, and I'm not going to, be saying anything that people don't know. Ventilator alarms are annoying because sometimes, especially in a sick patient, they're going off all the time. Okay, and again, I come back to the same kind of saying is that you don't have to be annoyed with alarms, you just have to know what's causing it. If you understand what the problem is, then you can make decisions on what to do, but it's not a freak out session every time an alarm goes on. When we worry about high peak inspiratory pressure, again, you know this, it's high resistance. Somewhere in the circuit there's high resistance. These are the possible causes which we talked about, and then there's ways of fixing them. The peak pressures are actually pretty easy to fix. Usually, it's seeing, is there a pneumothorax or injury, or does it sound like there's a lot of secretions there? So we suction, okay? If we worry about that there's a patient biting the tube, you put a bite block in, okay? Or are you worried that they might just have bronchospasm because they're asthmatic? You give them a nebulizer to open up their airways, okay? So peak pressures are pretty straightforward in terms of what's abnormal, okay? The issue we run into is when there's a low pressure alarm, we have to do a little bit more investigating, meaning, is there a leak in the cuff, which is checking that cuff. So low pressure alarms. So there's a couple things we worry about low pressure alarms. You worry about the actual volume is not being delivered. Okay, you're not getting the peak pressure and the plateau pressure you're hoping for. One, you look for a leak in the circuit, and honestly, you look if the ventilator is disconnected from the actual ET tube, which is not that uncommon. So assess your system and your circuit, make sure there's no issue, and also, again, make sure that the low pressure isn't because the patient isn't breathing in or there's something abnormal in the settings of your vent. When you look at low minute ventilation, it means you're not getting enough air into that patient, okay? Or the ventilatory rate or volume is too low. So really, you can see this with shallow respirations, or again, there's a leak in the circuit. It almost always comes down to you have to check your circuit in those situations. Okay. When we talk about apnea, it's important. Okay, mainly because no matter what you do, the ventilator itself is set in to deliver a certain number of breaths every minute, even if the patient doesn't trigger the ventilator. Okay, meaning that if you put in, you want 10 breaths a minute, every 6 seconds is going to be a breath. So if the patient doesn't trigger it, it automatically gives it every 6 seconds. Okay, what we worry about this more commonly is when we're using a BiPAP machine or pressure support ventilation. In order to get BiPAP or pressure support, one, the patient for BiPAP has to be awake enough to try and trigger a breath. And for being on a ventilator with pressure support, they still usually need to be able to trigger the vent. If they aren't triggering the vent, it usually means they're over-sedated or they're just not making an effort. The benefit on a BiPAP and a ventilator on pressure support, if they don't take a breath, the machine just does nothing. It gives them a breath, and sometimes it goes to a different mode automatically. Okay. And then self-extubation, like I said, if someone self-extubates, there's no alarm for that. You have to look and see if they're holding the tube in their hand, okay? I will say that, again, these are situations you contact the respiratory therapist, physician, that they've self-extubated, because frankly, you have to make a decision if they need to be intubated again, okay? So when we talk about troubleshooting, okay, always assess the patient first. Again, it's a dumb machine just giving air, okay? If you're not sure what's going on and we don't have an explanation in terms of why someone's not ventilating well, why they're oxygenating poorly, and you think that there's something, an issue with the vent itself, disconnect them from the vent and bag them manually, okay? One, you're able to salvage the patient by giving them oxygen, you're able to give them the volume you need, and you get a lot of information by how hard it is to bag. If it's challenging to bag because it's really kind of, the bag is tight, you might say, oh, well, there might be a mucus plug, or there might be something that's blocking the tube. Okay, if you run into a situation where you can't salvage them, then again, it's an emergency, but by disconnecting, bagging, and calling for help, then you have time to kind of figure out what the troubleshooting issue is and get them back on the vent. The second thing is when you look at an SpO2, when we look at the actual waveform, it really is just looking at oxygenation and saturation by kind of infrared light on your finger. Some people have cold digits. Some people have nail polish on. If you don't have a good wave, one, garbage in, garbage out, it's not an accurate sat. And then say you might have to look at a different spot on the ears, on the forehead. I'll say that one thing is you can't fake good when it comes to saturation. You can't get to 100% if it's less than 100%. So if it's low, you worry that it might be the wrong saturation, okay? The alarms, if you're ever running into issues in terms of needing to, from an oxygenation standpoint, again, you can try and increase the FiO2 or manually bag, and you can at least salvage the patient. I will say that honestly, we're in situations and we're not in the middle of nowhere. If we have enough help in the sense that if we think there's a problem, you have people to escalate up to. If you feel like there's something not right or the patient's not responding the way we want them to, talk to your respiratory therapist, talk to the attending, because again, critical care medicine is very much a team effort, and it requires multiple different sets of eyes to assess what's wrong and to actually make the right intervention. And then, yeah, again, bagging someone is always the right answer. So.
Thank you very much.
All right.
Dr.
Thanks,
Hodgin.
everyone.
Thank you.
Yeah, no problem. I'm here for after this question. Okay.
So we're going to go forward and talk about what our nursing care is going to be for our mechanically ventilated patients. So as you know, in our packing environment, we're going to put soft wrist restraints on our patients. We're going to maintain sedation, typically through propofol or Precedex, and we'll talk more about that in just a few minutes. We're going to follow the RASS sedation scale. That's the Richmond Agitation Sedation Scale. And we'll go through that in just a minute as well. But just so you know that the patients that are ventilated on a mechanical vent for a period of time, more than 24 hours, they're going to have a spontaneous breathing trial every morning to assess their readiness for weaning. Then with regard to our patient, if they are a bit wakeful, we want to be sure to reorient them to time, place, and events. And knowing that they are unable to talk to us because that tube goes past their vocal cords, give them means that they can communicate with us. So with regard to our cardiovascular, we want to remember that as we increase the PEEP, and especially when you first put a patient on a mechanical vent, that's when you could really see hypotension, because the body's not used to that, that peak pressure that's decreasing our venous return that could cause the pressure to drop. So with that, we might be giving them a little fluid bolus. So just something to consider. And also, our vented patient has insensible loss, so they too are at risk for dehydration. With regard to pulmonary, we're going to talk about ventilator-assisted pneumonia, and I'll talk about that a little bit more in just a little bit, but essentially we're going to be doing mouth care every 2 hours on our patients, along with suctioning when needed and keeping their head of bed up 30 degrees or more. And those three bundled factors have been evidence-based proof that really helps reduce the incidence of ventilator-assisted pneumonia, where that can occur in 1 in every 5 vented patients. With regard to GI, we're going to have to be considering their nutrition needs. And GU, these patients are going to have a Foley, so they're at risk for CAUTIs. So we want to be sure that we're doing the Foley care with our green wipes every shift. And then we're going to also be monitoring our skin closely for skin breakdown, from the ET tube area to even just turning and positioning, because these patients are sedated, they won't be moving on their own. And we'll be just very generous with our Mepalex ongoing prominences. So with regard to our sedation infusions, we're typically familiar with propofol in our PACU. Precedex a little less so. But with propofol, just a quick review, it provides just sedation and amnesia. It does not provide any pain relief. Our typical doses range anywhere from 5 to 50 mics per kilo per minute. You guys have that on your badges as well. And it is compatible with fentanyl and Dilaudid. But note too that when we start our propofol drips, that can cause hypotension as well. And because our propofol is in a bottle format, we need to use the vented tubing for that. And that because the rate will be low, we'll have to have a carrier fluid with that as well. With regard to Precedex, one more thing about propofol, as you guys know with your experience, it's kind of all or none. Either your patient's awake or they're out. You know, we can't really titrate in between too well. But that's where Precedex is more helpful, because with Precedex, we can find more of that twilight sedation where they can be a little awake, kind of responsive a little bit, calm, and you can even work to wean them in that state much better than with our propofol. But we see the Precedex more commonly in our ICU patients who are on a mechanical vent a longer period of time. Know that their big side effect for Precedex is bradycardia. And with this also, we don't titrate Precedex. We have to get doctor's orders to alter that dose. And lastly, remember that we're going to be doing the RASS sedation scale to be monitoring our levels of sedation for these patients. And that's what this is. And this is under our complex assessment in EPIC. And where we're shooting for on our mechanically vented patient is -2, -3. We want them lightly sedated, briefly awakening to voice, or to moderate sedation, where there is maybe a little bit of movement, eye opening, but no real eye contact. So they're with us, but they're not.
Somewhere.
I like that.
Can I say one thing?
Yeah, please do.
So one thing we talk about with sedation is if you see an ICU patient completely sedated, they're nice and calm and they're not doing anything, is acceptable after you've woken them up. So the idea is that a daily wake up is essential so they don't get over sedated. And frankly, it's shown to improve outcomes in the ICU. You think of sedation as the bathtub, that if you fill it up every single day and you never drain it at all, it just overflows. And it takes days for patients to wake up. This way, if you think about it, emptying the bathtub every day, assessing them, and then filling them up, the bathtub up a little bit more and not as much as you did before, is less sedation, less weakness, easier to extubate them. So even though people say, oh, I don't want to wake them up and make them miserable and uncomfortable, it really is important to wake them up on a daily basis. It does show significant improvements in outcomes of these patients.
And we do want to be monitoring our sedation Q hour with our vital signs. Regarding methods to prevent ventilator-assisted pneumonia, what we had said is that mouth care can't be stated enough how important it is. And this is what we have in the ICU. This huge bag is one kit for one 24-hour period. And Q2 hours, we're going to be doing mouth care. And with that, it is set up in that it has step 1, 2, 3, 4, all the way 12 steps, so that every 2 hours, we know what we're doing, and this will hook up on our IV pole so that we can't mistake it. So we'll start off in the morning, like 8 a.m. You will have your chlorhexidine wash and you brush your teeth. And then at 10 a.m., you do another swab and oral care. Then at noon, you would do swab. I mean, it tells you throughout the whole system. And then we will be doing chlorhexidine again 12 hours later. So this whole big kit is for one patient for a 24-hour period, so that we could do mouth care every 2 hours. In addition, we're going to be doing our inline suctioning, as Farzan had shown you earlier. Okay, suctioning is needed. And then we want the patient's head of bed up 30 degrees or more to help prevent ventilator-assisted pneumonia. In addition, we're going to want to be turning and positioning our patient every 2 hours. We're going to have the patient on SCDs to prevent DVTs and peptic ulcer prophylaxis. That's hard to say 3 times fast. With regard to our documentation, we're going to find our RAS score under complex assessment. Our vent flow sheet can be wrenched in. The good news is that our respiratory therapists will document the vent settings for us in Epic. They will also have it documented on the vent itself on a clipboard, so that when you get report and you get your patient's vent settings, you can check them with what they have documented. And then also you can check it on the machine itself. Okay, and then in addition, we can document all our mouth care, our position changes under our daily care safety. Our strategies to facilitate weaning. You want to take over on this?
Yeah, so I'll say weaning from the ventilator, I try and say liberation from the ventilator, because really what it is either on or off in a lot of ways. But the best way to ensure that patients are have the best chance every day of doing a spontaneous breathing trial is get them awake as possible. Okay, they need to be able to breathe on their own, prove that they can breathe on their own when they don't have an ET tube in. Get them in the right position. Remember, a patient laying flat on their back is going to be at a much more disadvantage in terms of breathing than someone sitting straight up in a chair or in the bed in a chair kind of formation. It just gives them the best advantage in terms of anatomy. You can give them pain relief in the sense that some patients are just agitated and jittery because they might be older and have back pain. They've been laying in a bed for 3 or 4 days. So if they're saying that they have pain, try and treat their pain enough to get over the hump, but not sedate them so much. Okay. Don't try and overdo things, meaning that right before you're about to try and extubate them, you have the physician put a line in, or you do something really uncomfortable that's going to agitate them even more. And frankly, make things nice and calm. I think sometimes, most of extubation is calming the patient down because they're in a very stressful situation. They're worried about what's going on. And honestly, if in older patients, they might be a little bit disoriented. So talking them through it, making sure they understand everything is calm. If they're meeting the requirements for a successful SBT or spontaneous breathing trial, taking that tube out is the best thing for them. Now, I will say that there are good studies that show that 10% of people that you extubate will be reintubated. Okay? If you get to 10% of that reintubation rate, that means you're being aggressive enough of trying to get ET tubes out, but you're not being cavalier in that you're taking tubes out too early. So every single day, you do it again. You check. If they fail one day, you check the next day. The same way to meet all of these kind of directives to give them the best chance for getting the tube out and keeping it out.
Very good. This is like right almost back to our beginning again. We're going to see these same symptoms as we're feeling. So that's about it. So thank you very much for your time.
Questions at all about anything we talked about?
Do you change the vent setting when you're weaning?
So it depends. A lot of times what we try and do is simulate what they would be like without a breathing tube. So a lot of times we'll put them on pressure support prior to weaning. And depending on the physician or the patient's kind of individual case, usually we'll say they need to be able to maintain at least good ventilation on their own with some support for at least 30 minutes. Okay, that's what we say. Well, they're doing well. They're not, getting hypertensive. They're not getting tachypnic. They're oxygenating appropriately. They say that's a passing an SBT trial, a spontaneous breathing trial, and they may be appropriate for extubation. If they fail, it means, okay, well, they didn't fail today. Sedate them calmly again, but not as much, and then we check again. but we go back to those same settings, usually pressure support with a little bit of support, but enough to try and maintain that if they took the tube out, they'd be able to survive on their own.
Any other questions?
Yeah, there's a lot of different ways of doing it, and also it depends on the respiratory therapist and the medical critical care patient, who's a physician who's overseeing the patient.
Thank you, Bobby.
Cool, thank you guys. If you guys have any questions or anything, feel free to just give me a holler and ask, okay?
Thank you. Thank you again. So Frozan is just going to show us the vent here, and she's going to detail, if you want to come closer, you can just see where you can see the vent settings on the front of the machine itself.
So I'm just gonna show the basic stuff on the vent, of course, on the floor and ICU. The respiratory therapist is the one that's making the changes per doctor orders, but I'm just gonna show you basic stuff like when you get the patient coming from the OR and then you have to connect the patient to the vent until the RT is coming. So basic stuff, so starting from turning on the vent from the back. We have a button here that is going to get flipped, and that's the place that we turn on the vent. And then, of course, from the side there is exhalation port and inspiration port. We have filter. We have battery reserve there in the back. Of course, we have the air connections and the oxygen connections that goes to the wall. And then most important thing, that patient to patient, we change the filter on the vent, which is coming out from here. That goes to the decontaminated room and get clean with alcohol and get dry and processed, and we are using back for the next patient. In the front, for you as a nurses, so just basically, Dr. Mahajan talked very detailed about mechanical ventilation, so I'm not going to repeat anything. I'm just going to show you general, the most important. We have the adult button and we have the pediatric. So it's really important before you turn on the vent to see that which mode you are. In case if you're not in adult mode and you turn it on, so all the measurement that you're gonna put for tidal volume, respiratory rate, and all that, your tidal volume, you cannot put more than 200, 300. So it's very important to make sure that you are in the adult mode. This is the button that we turn it on and activate the vent, and also you can press it back, make it standby. So when you turn it on, there is a button showing all the modes that Dr. Mahajan talked about it. I'm gonna turn off this because it's gonna make noise. So we have, as Dr. Mahajan was talking, you guys not gonna change any modes. You're not gonna be able to change any changes on the modes. That is all going per doctor, per MD order. And the respiratory therapist is the one that's changing on the vent, and also the respiratory therapist is the one that managing this vent with the patient's blood gas. But for you as a nurse, it's very important you have to make sure that you are watching the patient tidal volume, the patient minute ventilation, the patient respiratory rate, and the oxygenation. And the only button that you can use here is O2 delivery. Like when you're suctioning the patient, closed suctioning, and you want to give oxygen to the patient, so you press the O2 delivery button, and that will give 100% oxygen to the patient before you are suctioned. That's all you can do. But the rest of the management is with the respiratory therapist. Different modes. The most important and famous mode that we are using in here is PRVC, pressure regulated volume ventilation, and that's for all the patients we are using, because the vent is very smart, sensing the pressure and giving the patient precise tidal volume.
May I just, one very important thing, and as you said, the one button that we can press is our O2 breaths, where we're gonna provide a minute of 100% O2 prior to suctioning our patient. So we can press that button, it'll give the patient 100% oxygen for just a minute, then we can inline suction the patient, and then when we're done, we can press that button again to give the patient another 100% O2 for 1 minute, and then it automatically will go back to its previous setting. So just to remember that, we always want to pre-oxygenate before we suction.
Another important thing is like the capsule. We as a RT on all the floors, the ICUs, we have a capsule and we connect it, and all the data from the vent will go to the Epic. But you guys as in PACU nurses, if you don't have that capsule, so you're not gonna be able to see that on the Epic. So, and if we are we are having a patient in PACU, and I'm as a RT, so I will come manually and put all the data from the vent manually to the Epic for the documentation purpose.
Under vent settings.
Under vent setting, yes.
That's great.
And then we talk, Dr. Margin talk about alarms, which is very important, and also he mentioned the worst case, sometimes vent is just alarming, and it's getting frustrated. The best thing is disconnect it from the patient until RT is coming, so you just bag patient with the ambu bag, and ambu bag is the best friend in emergency situations. So until the RT comes, you can suction bag the patients until the therapist will come and help you.
Thank you so much. Does anybody have any questions? Well, thank you again. Thank you for your time.
Thank you.
Good, thank you, Farzan.